Now, I myself, my name is Roman Müller. I'm professor of translational nephrology in Cologne. And my job is actually in between a basic research lab I lead to the clinic. In the clinic, I have a specific interest in genetic kidney disease, and we've built a large genetic kidney disease unit here in Cologne over the last years. And what we noticed, well, over more than a decade now, is that we were getting more and more patients with genetic kidney cancer syndromes that had not found really a contact point anywhere else before, had either not even been diagnosed before, didn't know what the cause for their disease was, or on the other hand, had never found anybody who could explain to them what was happening and why they had this and how to take care of this and why this is different from other forms of renal cell carcinoma, also as to the treatment strategies and the monitoring strategies. And while this was getting more and more, and we really felt the need to do something else there, we also sat down and said, you know, there is some entities for which there is some support and organization and networking. There's some other more blank spots still in the field. And we felt, together with Christian and his expertise, that reaching out, building a network will greatly help medical care, will help the patients, and will also help to move towards the next steps in research in this field to allow for finding new diagnostic and therapeutic strategies in the future, and really pick the brains of key people that are really experts and allow them to facilitate their work. And after sitting down there and thinking about what would be our aim, we reached out to other players in the field and came up with the first idea, what could be the mission for such a alliance, and that's our current view on this: improving quality of life and health for patients with HLRCC through providing a platform for patient advocacy initiatives, research, excellent education, and networking of caregivers, researchers, patients, and their families. Now, it was very clear from the early beginning, and we're very grateful for the interaction with many different people, including Graham, but also Dean Elhagen and Jay, that we needed to do this as one aligned effort together with the HLRCC Foundation. And we've become very close partners over this time, over the years. And we're quite happy that this also led to close interaction with other associations in the field, allowing for support in building this. The European Renal Association is now one of our partners, the European Rare Kidney Disease Reference Networks, and those that are not from Europe may not be aware of that, but in Europe, the European Reference Network has become the key entity that allows for taking care of rare kidney disease patients and facilitating research in many different angles. And ERCNet is the one that focuses on kidney disease. We're now partnering and collaborating with the urology part there and the rare tumor syndrome branches there as well. We've become an affiliated organization of the International Kidney Cancer Coalition, and we're expanding this network. While this is the society side to it, what's even more important is that really key experts in the field have joined this effort over the years and are trying to move this forward together with us, including researchers, clinicians, and patient advocates from 3 continents, more than, I think, 8 countries now, and more than 30 experts that are willing to invest here and meet regularly and build this. And this has already led to the first real touchable initiatives. You may have noticed we don't even have a website or a logo yet. That's work in progress. We wanted to do something substantial first. Now we're currently working on the first statements, focusing on pathology on behalf of the Alliance, to come towards some of the key aims that we have together, building a network of excellent basic research and clinical experts on HLRCC and patient advocates, creation of an international HLRCC registry based on the ERCNet infrastructure that really will allow them bringing the information where patients are, clinical characterization together to really collect, because we feel that there is much of an underdiagnosis going on, setup of an international biobank to facilitate outstanding research in the field. And there's several colleagues involved on that side, Christian, Frezza, but also Aixeng is one of these partners and education of clinicians to allow for the formation of HLRCC excellence centers down the road. This feels very important because currently, in my view, patients are often left alone with this a bit, and takes a long time to find the experts. At least that is what I know for the German situation. One of the things that are already ongoing on the way to building these networks is a survey to collect the information. Where are patients treated in the world? How many patients are there? All of this information is still not complete to date. And the survey was set up on the ERCnet infrastructure, is currently running, and is directed to clinicians in the field to report just very simple things, won't take much of your time. And we've already collected quite a large cohort of patients like this to answer the question, do you treat patients, and some very rough characteristics, summary characteristics, no individual patient data or anything, 2 to 3 minutes to start building the registry down the road. There's an email address you can use to contact us and be part of the network. We're happy about any additional partners. And with that, I finish my introduction. We'll have 3, 4 actually talks now today. And we're very glad that we'll hear from Jan Degenhardt, who is a physician in our unit here, who's focusing on the care of patients with genetic kidney cancer syndrome. I'm especially glad about the fact that Laura Esfeller agreed to provide her perspective from the patient point of view. Where are the needs? How is the patient journey? Christian Frezza will tell us more about fumarate hydratase, so the enzyme that's actually non-functional or dysfunctional in HLRCC. What do we know so far? And equally important, and I'm actually really happy that Marston, you agreed to join this effort today and help us with your expert opinion. I guess all of you know Marston Linehan as one of the clinicians when it gets to genetic kidney cancer syndromes and also HLRCC, how HLRCC renal cancer can be managed to date, and also maybe where there is more need for information and for data and study data in the future. And with that, I finish. There is a couple of quick housekeeping notes. We cannot provide individual medical advice in this meeting, but we're of course very happy to address any general question in the discussion. There are experts for all aspects of HLRCC on the panel of the symposium, whom you can see as panelists. Neil, Rajan as for dermatology, Outi, Uimari when it gets to the OB/GYN aspects, Marston himself, Christian, Arndt Hartmann as an expert pathologist, and Dean Elhack from the oncology perspective. Niels Große-Hochkamp is an expert radiologist in the field. So we're happy to take all questions. Please use the QA option of Zoom for your questions. Comments will not work. The QA section is the key tool to use. And with this, I finish and hand over to Jan, who actually is also the key person keeping the entire alliance together. Thank you very much for these efforts, Jan, and for the organization of today's symposium.
Yeah, thank you a lot for the introduction, Roman. So my part will be to give a short overview about the clinical challenge that poses HLRCC to us physicians. I will try to cover all aspects while going a little bit beyond the basics, but I will stay clear of any instructions regarding therapy of RCC or further insights into the biology or underlying mechanisms of FH deficiencies, and that will be covered by Christian Frezza and Marston Linehan. So this will consist of a brief history of HLRCC, the clinical characteristics, and then the current approaches to diagnosis, screening, and surveillance in HLRCC. As most of you know, the first description of HLRCC is quite a while ago, been published in 1973 in a dermatologic journal by Reed and his collaborators. He looked at 2 families who had cutaneous and uterine leiomyoma. Similar cohorts had been published earlier from Italy mostly, but in this 2 families, there was one patient, a young girl with a renal mass. At the time, the diagnosis and treatment of kidney tumors was not as advanced as it is today. So the way to help that patient was the complete nephrectomy. And in fact, a tumor was found invading the kidney tissue. And the patient also exhibited all other hallmarks of HLRCC syndrome with the cutaneous leiomyomas. The reddish color can obviously not be seen as typically as it is today, and also large uterine fibroids in this young patient. This was the first description of all typical HLRCC manifestations. However, was not recognized as part of the clinical syndrome. This was coined hereditary leiomyomatosis at the point without the RCC part, since it was a single occurrence in one patient. Then it took a few years. So more than around 30 years later, Leiomyomas et al., a researcher from Finland, made the connection between uterine fibroids and renal cell carcinoma. He examined 2 families and was in fact also able to pinpoint the location of the mutation or of the genetic alteration in HLRCC to a section in chromosome 1. And this was the first description of HLRCC as we know it today. So while it took close to 30 years for recognizing the whole HLRCC syndrome, then it all came together rather quickly. 1 year later, Multiple Leiomyoma Consortium published a paper identifying the FH gene on chromosome 1 as the cause for HLRCC. Afterwards, a lot of mutations have been identified, but to date, no clear genotype-phenotype correlation, meaning that the mutation specifically predicts the clinical manifestation of HLRCC syndrome, can be made. We have also gained knowledge into other organ manifestations of HLRCC that might not be as usual, but are still part of the spectrum we observe. This would be renal cysts and also paraganglioma or pheochromocytoma, which are endocrine tumors not deriving from the kidney tissue itself, but from the adrenal gland located close to the kidney. The insights we gained regarding the role of FH and the implications for tumor predisposition have sparked some discussion about the nomenclature of HLRCC or of FH deficiency tumor predisposition syndrome. And there's one way to look at this distinction that I think makes a lot of sense. So FH deficiency tumor predisposition syndrome was ascribed to all patients who have a germline mutation of one allele of the FH gene. This does not mean that the patients do require any manifestations, skin, uterine, or kidney, but they still carry the predisposition to develop FH-deficient tumors going on. HLRCC would be the description for the syndrome that occurs when FH-deficient manifestations occur in several organs. And there are one manifestation that's linked to a pathogenic FH mutation in the germline. So from birth on would be enough. And these 2 conditions would always require a person to be carrying the mutation from birth. There is, however, a further entity that occurs in the setting of FH deficiency, and that would be sporadic FH-deficient renal cell carcinomas. These are renal cell carcinomas that show also a loss of the enzyme fumarate hydratase, but they occur sporadically. There's no germline mutation, and after complete removal, for example, of the renal cell carcinoma, we would not suspect such patients or persons to carry forth an increased risk for other manifestations of HLRCC. If we want to visualize this fact, we can look at it as an overlay of a few different cohorts. There are people who have a FH germline mutation. They have the FH tumor predisposition if this mutation is pathogenic. Then there are people who have leiomyomas, or they have leiomyomas and an FH deficient RCC, and they would cover the whole spectrum of HLRCC syndrome. But HLRCC requires some form of organ manifestation. And then there's, of course, the cohort who has only sporadic FH deficient renal cell carcinoma, but no germline mutation. So if we go one step further and ask ourselves how frequent is HLRCC, we can arrive at conclusions in 2 steps. So one step would be to ask how frequent are these pathogenic germline FH variants? And one member of our alliance took a look at this. We would ask for a number, which would be the prevalence of these pathogenic germline FH variants. So the fraction of people in a given population, for example, 1,000 people who have a pathogenic fumarate hydratase variant. And the other question we can ask would be how many with these pathogenic germline variants will actually develop organ manifestations of HLRCC? And this would be a matter of penetrance. Penetrance means the likelihood that a given genotype, a mutation, also represents in some form of clinical manifestation, a leiomyoma or renal cell carcinoma or uterine fibroid. If you have any of these, HLRCC is penetrant in this case. And we know HLRCC can express itself in various ways. Some people have very severe leiomyomas. Some people are very lucky and they have less problems with leiomyomas. And of course, there's also variability between maybe male and female persons. This would be regarded as expressivity in that setting. So to answer the first question, Brian Shook of our alliance took a look 2020, and he had a data set of genetic information from a large cohort of patients. These patients were tested unprompted, so there was no moment of risk involved, no renal cell carcinoma that led to the testing, and he derived a frequency of pathogenic mutations or mutations of interest of around 1 to 1,000. These mutations were further stratified or separated into mutations with a very high impact, suspected impact, and mutations with a lesser suspected impact. And when they connected the genetic data with clinical data from these patients, they found the lifetime renal cell carcinoma prevalence between 1.7% to 5.9%, according to the different risk levels of FH variants. So this prevalence can obviously not be applied to the HLRCC population, since all these patients have been tested without a moment of risk. So if we talk about the penetrance or occurrence of various organ manifestations, we have to look at them very separately because they differ quite a lot. So I will first talk shortly about leiomyomas in general. These are the manifestations with the highest prevalence in HLRCC, and they're usually histologically benign, although rarely transformation into a form of cancer called leiomyosarcoma has been described. And the cutaneous leiomyoma seem to occur a little bit earlier than the uterine fibroids, as you see in the graph on the red side. And one advantage of the cutaneous leiomyomas is that surgical removal can already lead to a correct diagnosis if the correct pathologic assessment is made. On the other hand, it's often a necessary requirement for the complete therapy in the setting of uterine fibroids. To further detail the cutaneous leiomyomas, they show an age-dependent increased prevalence and also increase in size and number over time. And they significantly contribute to the burden in HLRCC because they are very painful and very sensitive to temperature. There has been a variability of treatments examined, but there's no clear standard, and this has to be decided on an individual basis on the extent of the leiomyomas, on the location. So one option is always excision, especially in the setting of solitary leiomyomas, or even if histology is still needed in case of suspected HLRCC syndrome with no established diagnosis yet. On the other hand, less invasive options include cryotherapy, topical anesthetics, or other topical treatments. Some of them are derived from other hereditary skin tumor syndromes. And also forms of ultrasound ablation or laser ablation have been evaluated. In general, cutaneous leiomyomas and uterine leiomyomas, to a lesser extent, are a little bit less in the spotlight than the renal cell carcinoma because they are not inherently lifetime limiting. But we have to really make clear, although they are histologically benign, they are a considerate burden regarding pain and the generally aesthetic problems coming with cutaneous leiomyomas. So for uterine leiomyomas, this is similar, but since uterine fibroids also occur in the general population at a high frequency, we can examine the differences between the HLRCC population and the general population. And one member of our alliance has done this. FH-deficient uterine leiomyomas occur earlier and often in multiples than in the general population. On the right side, you see a very large multiple leiomyomas in a young patient from a publication of last year. And here it's similar to the cutaneous leiomyomas in that the treatment approach has to be very individual, depending on the intended family planning and possible complications stemming from the individual situations with leiomyomas, since they can negatively affect fertility or affect miscarriages. There is the option of hormonal treatment, but sadly, hysterectomy is often required, and this is a very negative impact for the reproductive health in HLRCC. And the last manifestation, of course, is HLRCC renal cell carcinoma. And HLRCC renal cell carcinoma really behaves different from other forms of renal cell carcinoma. I think you all have heard that it's often advanced and aggressive at the first diagnosis. And this first diagnosis is earlier than in the general population of sporadic renal cell carcinomas. On the right, you see a age distribution histogram of the number of patients diagnosed in a specific age group with a renal cell carcinoma. And this hinges around patients in their 30s and 40s, early 40s, who are diagnosed with a renal cell carcinoma, which is in the general population more seen in males and also 2 decades later. On the left, there's 2 cohorts compared. In blue, a cohort of hereditary kidney tumors, and these are all forms of hereditary kidney cancer. And on the right side, the yellow plot is a cohort of sporadic renal cell carcinoma, and these separate quite nicely, but of course, this does not differentiate between the different forms of hereditary kidney cancer. So this is always a possible diagnosis in case a patient gets diagnosed with renal cell carcinoma early in their life, and should prompt the assessment of extrarenal HLRCC manifestations or all extrarenal manifestations, in fact, if a kidney tumor is diagnosed at a young age. So how do we test? How do we proceed from this? So a patient has been diagnosed at a young age with the kidney mass or kidney tumor, and there exist, in fact, multiple guidelines or gold standards for testing for hereditary cancer predisposition or even kidney cancer predisposition syndromes. These are not uniform, but they usually involve some form of questionnaire regarding HLRCC characteristics at diagnosis and extrarenal manifestations that can be linked to specific syndromes. On the other hand, little guidelines indicate genetic testing on the basis of uterine or cutaneous manifestations alone, except in the case that specific histologic findings like FH deficiency have been demonstrated in these lesions. In general, when we refer patients to genetic testing, we always have to balance 2 parts out, this over-testing on one side and the misdiagnosis on the other side. So in HLRCC, this is quite clear. So the misdiagnosis of an aggressive renal cell carcinoma clearly favors genetic testing in HLRCC. So how do we decide who we refer to testing? Ideally, we want to test patients before they develop RCC, because surveillance and early detection of renal masses is paramount to ensuring good outcomes for HLRCC renal cell carcinoma. We should consider genetic testing for any first-degree relative of an HLRCC patient. We should also consider it for early onset uterine fibroids and for cutaneous leiomyoma, if specific characteristics occur, for example, multiple leiomyomas or pathological characteristics. And also if renal cell pathology, RCC pathology, shows distinct features. For the general characteristics of renal cell carcinoma, it's the young age at diagnosis, the multiple or bilateral kidney tumors, the family history, and presence of extrarenal manifestations that should prompt evaluation of genetic testing. But as you see on the right side, it's a quite heterogeneous composition of possible diagnoses. This ranges from the marked in red diagnosis who have very apparent extrarenal manifestations and can be more easily clinically diagnosed. But we have also other forms of hereditary kidney cancer syndromes like HLRCC or CHEK2 associated renal cell carcinoma, who are less obvious in their clinical presentation. In general, we suspect 1 in 20 RCC, around 4.8%, to be linked to hereditary kidney cancer syndromes. So how do we identify HLRCC among all those at-risk patients with early renal tumors? This hinges around the RCC pathology, and you see here a few features that are distinct for HLRCC-associated renal cell carcinoma. Sections A and B, they demonstrate histopathological patterns. On the left in pattern A, you see budding structures or bulbs of cells in this staining, and in B you see cells that seem, or tissue that seems like it's in disarray, very chaotically organized, and the presence of various features that are quite different from another but occur in the same tumor can be characteristic for HLRCC-associated renal cell carcinoma. In section C, you see a larger magnification, and if you look very closely in under the magnifying glass, you can see eosinophilic or orangophilic, that means reddish or reddish to yellowish structures are close to the cell nucleus, and this constellation was coined papillary renal cell carcinoma type 2 up until recently. Since we now understand how FH affects the formation of renal cell carcinoma in HLRCC, we can also look after FH under the microscope. And in section D, you see regular kidney tissue, and the brown sections are expressing fumarate hydratase. Section E is fumarate hydratase deficient renal cell carcinoma. There are still some brown spots, but these are limited to in between the kidney cancer cells. One limitation of this approach, using only FH or fumarate hydratase under the microscope, is that around 20% of FH deficient renal cell carcinoma still stain in some weak form for fumarate hydratase. And there we would like to introduce special staining called 2SC staining, which really can demonstrate the loss of FH function in the kidney tumors. These are some pitfalls. So the FH loss is not fully sensitive, and on the bottom line is that the communication of the clinical suspicion is critically important between the pathologist and the urologist or oncologist referring a sample to the pathologist, because only then the pathologist can really decide to go the whole route in testing for FH deficiency in the sample he is receiving. And one other caveat would be the presence of non-papillary renal tumors like collecting duct carcinoma or even paraganglioma or a hybrid oncocytoma in the setting of HLRCC. Okay, so returning to the screening and surveillance, you have talked about who should be screened. In the setting of FH deficiency, obviously, people who have FH deficient renal cell carcinoma should be screened for germline fumarate hydratase mutation. But the other thing would be people with a FH germline mutation who have not yet developed or have stable organ manifestations of HLRCC should be monitored. And that results in the HLRCC surveillance strategy, This is a suggestion by Jean-Baptiste Latouf, who is also part of our alliance. This cannot be generalized to the whole world. It can vary between countries. At which age specifically the surveillance should start and be conducted. For skin, a dermatologic assessment for leiomyomas can start at age 8 and be continued annually. For the uterus, gynecologic evaluation, including a pelvic ultrasound, should start at age 21 and should be repeated annually. And the very relevant section would be the monitoring or surveillance of kidney manifestations. An MRI of the abdomen can start as early as ages 8 to 10. This hinges around a few case reports reporting about RCC in young children from the age of 7. So this would be done once and then continued at the age of 18 and repeated annually. Also, ultrasound of the abdomen can start at age 12 to use a less intense monitoring modality. I will stop my talk about surveillance here and return to the multidisciplinary challenge that poses HLRCC. So during the talk, I think I demonstrated that urology, dermatology, gynecology, pathology, oncology, radiology, and genetics play a role. Nephrology is a rather new player, but as Marston will discuss later, a very important option is nephron-sparing surgery, but this cannot always be done. And since it's our organ, we feel that we have a responsibility for the patients and monitoring and following up on their renal health, even after they develop RCC. Of course, this cannot be done alone from a clinical setting, so we are dependent on the basic researchers. We supply them with hypotheses from our clinical work, and they supply us with results of their basic research, maybe enabling new therapeutic approaches. And of course, we are all interested in the exchange with the patient advocates who can most accurately communicate their needs and questions regarding their condition. But I think in this alliance, we have demonstrated that we are able to build all these pillars of the multidisciplinary approach to HLRCC treatment. And with that, I want to close and thank you all for your attention.
Thank you very much, Jan, for this nice overview. We have one question in the Q&A section that I will quickly read out, and we'll keep this short for matters of time. Christian is also typing a more extensive answer, but Christian, maybe you quickly want to address this here with a short answer. The question is that it feels like to date the research has been targeted to the renal aspects, but has there been research on the impact on other organs and systems aside from uterine fibroids or cutaneous leiomyomas?
Yeah, I think the patient here is absolutely, or the person who asked the question is absolutely correct. A lot of the work has been done in kidney cancer from the molecular point of view, for sure. Some work has been done on skin lesions and some in the uterine fibroids. But from preclinical work, I can say that we are working a little bit along this line, and I will, maybe mention something more specifically in my presentation. But yes, the person is absolutely correct. We need to do more in these two other areas and in other organs as well.
Also considering the frequency of potentially disease-causing mutations, right? That's something we still need to understand much better, and then what impact that could have on other organs.
Absolutely.
Are there other quick comments at this point from the panel? Otherwise, we still have the chance to discuss the entire overview of talks today at the end in the conclusion section. If that's not the case, I would now again welcome Laura, who will be the next speaker here. Laura, looking forward very much to your presentation.
Thank you very much. Hello, all. My name is Laura Esfeller, and this is my Twitter/X handle. I am an 8-year survivor of stage 4 HLRCC. Next slide, please. So I was diagnosed with uterine fibroids in my early 20s, and then began developing leiomyomas on my back and my arms in my late 20s. And my doctors at the time weren't very concerned. No one had discussed HLRCC with me, which I think is a very common experience amongst most patients with this condition. I began experiencing some other symptoms like elevated blood work, and in addition to having extreme fatigue, high blood pressure, for about 2 years. And then unfortunately, I was diagnosed in the ER 5 days after my 29th birthday with stage 4 papillary renal cell carcinoma, which was related to HLRCC. I'm really fortunate that I've lived long enough that my initial diagnosis is a little misleading, because I was diagnosed with papillary in the beginning. I had a radical right nephrectomy along with my right adrenal gland removed, most of my vena cava because of a significant tumor blockage in my vena cava, and along with 7 lymph nodes at UCLA in June of 2016. And then my first post-op scans in that August showed that I had extensive metastatic disease to my liver, my lungs, and most of the lymph nodes throughout my chest. So I, at that time, because there was no real standard of care for papillary metastatic patients, much less HLRCC-related patients, I enrolled into a clinical trial through SWOG called PAPMET, and that was in September of 2016, and I was randomized to cabozantinib. Next slide, please. Miraculously, my first scan on treatment that December showed an 80% reduction in my tumor burden on the cabo monotherapy. And then I was declared NED in August of the following year. I discontinued cabozantinib due to side effects in April of 2020. And very fortunately, I've been NED up until January of this year. I have scans in a few weeks, but I'm on a 6-month surveillance scan regimen now, and my treating oncologist is Dr. Shook at UCLA. Next slide, please. I recognize I am incredibly fortunate to have had the complete response to treatment that I did, and that it seems to be at least fairly durable at this point. But as I'm further along in my journey, I question, where do I go from here as a stage 4 kidney cancer survivor with HLRCC? I really encourage all patients to make sure that they are seeing a specialist in the field. We have a lot of wonderful oncologists throughout the globe, but because this is such an incredibly rare subtype of a relatively rare cancer, it's in my opinion, crucial to be seeing a specialist that is familiar with HLRCC and FH deficient renal cell carcinoma. In addition to that, making sure that your family members are screened. I know this is a delicate topic for a lot of patients, but I really cannot stress enough how important it is that if you have a loved one in your family that's been diagnosed with HLRCC, especially if they've been diagnosed with renal cancer at a young age because of HLRCC, how important it is to have that screening done. I've actually pictured here on the top right a picture of my mother, who I unfortunately lost to kidney cancer about 3 years after I was diagnosed. My mom had decided not to get screened for HLRCC, unfortunately. And, I don't know that it would have changed her outcome, but I know it certainly would have given her a running start had she gone ahead and been tested. I also firmly believe that we need to have our space in the field of research because this is such a relatively young syndrome, all things considered, right? 30 years is not a long time in the grand scheme of things, that it's really important that we are providing our tissue samples, that we are participating in clinical trials when they're available to us, because I do believe that there are more HLRCC patients and FH, syndrome patients out there that just haven't been diagnosed yet. As I said, I was showing symptoms of the syndrome for almost 10 years before I was diagnosed with HLRCC, and it came in the form of a stage 4 diagnosis. And I don't think that I know for a fact we will not get the answers that we need about this syndrome and how to treat it without participation in clinical trials and providing our tissue samples, our blood work, anything that can be beneficial to the scientific community as we try to answer these really critical questions. And additionally, I asked myself, why is it important for us to be visible? Over the last 8 years, I've become a really involved patient advocate, both in the kidney cancer community and within HLRCC specifically. And I think it's important for a number of reasons, although I don't want to be the only person in this field. So I'm really grateful that we have people like Dean and Jason and many others that are visible. But we need more diversity and more patients and caregivers sharing their experiences and stories, because again, I don't think this is as rare as we believed that it once was. And we will not find answers without sharing our individual experiences. I know that, again, my experience is very rare as a stage 4 patient, and I don't want to be rare anymore. I want for other patients to have those same experiences. And I don't think that happens unless we are being open about our stories. I also just think that it's really important that we are visible because of the fact that so many of us, our touch points are, our initial touch points are with providers that aren't in oncology, right? I was seeing a dermatologist, I was seeing an OBGYN for many years before I was diagnosed. And the reality is that, even after my diagnosis, I've had to educate my OBGYN before, on HLRCC. I've had to have those conversations with dermatologists before. And, the more that they are aware of our cases, the easier it is for them to identify patients like us before it results in a stage 4 diagnosis. And also, quite frankly, the more visible that we are, the more funding opportunities become available, either through pharmaceuticals or for government agencies for research to happen. And so that's why I'm a very strong advocate for patients and caregivers sharing their experiences so that we can collectively work together to have a brighter future for all of us. Next slide, please. One of my mantras lately has been no decisions about us without us. I think it's incredibly important, and I really appreciate the foundation today for allowing me to share my experience, because we as patients and caregivers provide an experience and provide institutional knowledge that you quite simply can't replicate in a lab or in a clinic or on a surgical table, correct? I spent 4 years on cabozantinib and went through all the side effects and know it very intimately. And I'm really glad that we have more than monotherapy available for patients now with stage 4 kidney cancer. But, that's a lived experience that I have that it's impossible to replicate, without sharing that. And so it's why I feel very strongly that we all have a seat at the table when it comes to designing clinical trials or discussing research opportunities, because that's something that we can provide a different perspective that really can change the dynamic of where we're going. So I really encourage all of you today that are patients and caregivers listening to, no matter where you're at, whether you have HLRCC but no cancer, or you have both, your voice is powerful. We need you in the field. We need you visible. It can help pave the way for more treatments and longer lives. This is why I've decided to dedicate part of my life to patient advocacy, because, selfishly, I know that I may have to go back onto treatment at some point, and I want to have a brighter future for myself, the patients that we've lost along the way. I think it's important that we honor them by sharing our stories and being a part of clinical research, and making sure that we are, really paving the way for whenever the next 30 years come, we have plenty of answers and a clear treatment plan for HLRCC. Thank you so much.
Thank you very much, Laura. Again, this was wonderful. And I can only thank you again that you were ready and willing immediately to share your story so openly today, because it is, you know, it is impressive. It raises thoughts and also concerns about some shortcomings we still have in the medical system for caring for the rare in general, but here specifically. But it's also encouraging, and that is great, because that encourages other people and you know, with HLRCC and beyond to contribute. And I can only again, you know, emphasize what you said. This is an effort. All we're doing here together can only be done together. If all stakeholders and their people with HLRCC are central to this effort, come together and help. It's an interdisciplinary problem on the medical side, on the research side, and it needs patients that are willing to work together with the experts and the clinicians in the field to move this forward. There's a lack of patient advocacy groups actually in this field compared to other diseases as well. There's some diseases for which there is more going on already, which makes it even more difficult for patients to start networking. This is something we're very ready to help with. So also I can say to all the participants today, if you are a patient with HLRCC and are willing to contribute there, or want to network and get in touch with other people, reach out to us. We can also help, and that's something we're already starting right now. For Germany, for example, there's nothing really going on yet, right? So this has to be kickstarted, and we have umbrella organizations like IKCC, like ERCNet, like the European Kidney Health Association, FEDER. There's many others that are very much willing to help you out. It's nothing where you have to feel, you know, this is something I've never done. I don't know what to do, how to do this. This infrastructure can be provided, but we need people to come on board and help us out there. And with that, Laura, I have one question for you. And then there may be more from the panel and also the Q&A section. And that would be how long did it actually take for you, what you would feel was like the first manifestation now in the hindsight, right, of what was HLRCC, to actually get towards a diagnosis and someone who could take care of the full clinical picture?
Thank you for that question. And thank you again. I just want to emphasize how important it is and how much I appreciate that you've allowed me to share my experience as a patient. I often joke that I'm not a scientist, I'm not a doctor, right? I went into marketing and public relations for my career path, but you know, we all have a seat at the table. So thank you for that. For me, to answer your question, you know, looking back, it's actually ironic. I'm actually in Las Vegas right now and overlooking the clinic where I was dismissed, quite frankly, for almost 3 years. 3 years I went to my doctor, my primary care doctor, along with you know, my other physicians, my other specialists, raising concerns, and had honestly almost given up on trying to get an answer. And it wasn't until my vena cava was blocked and I had, you know, severe back pain and my legs were swelling from edema that I finally got the answer that I wasn't looking for. But it honestly was a relief in a way to know that there really was something going on.
And it also shows, right, that, I mean, people with, while all rare diseases and all genetic kidney cancer syndromes are much more common than most people think, the individual entity is still rare enough that, you know, people don't expect such diagnoses in a young woman, right? And
Yes, yeah.
that makes it much more difficult to come to the right point in the beginning. And in my view, it's, as far as I've seen so far, a journey over many years often until you find somebody to take care of you. Even in the obvious cases, like, right, where you have positive family history for generations, and still nobody really picks it up. And that's also why even simple tools and education can help. If you have a family history on your patient, right, you're very often able to change the path. But Neil raised his hand and also had a question or comment here.
Yeah, thank you. Laura, thanks for sharing that. It's a real privilege to, you know, get that narrative, and it, you know, empowers, I think, many of us on the panel and on the call to really keep pushing forward to raise awareness. As Roman's just touched on, there's often this whole hurdle with any condition that's deemed as rare, where, you know, people are exactly as you say, sometimes dismissive, there's sometimes a lack of education, there's a lack of awareness. And, I would strongly, encourage all of us on all the fronts that we can to try to raise the profile, at the level of the family physician, at the level of the treating, say, dermatologist. I guess, in the skin space, we're privileged because potentially we can phenotype and detect leiomyomas and think, look, that needs a biopsy, we can't just dismiss that. And then that can lead down a trail where someone gets preemptive screening and, early intervention. So I really, congratulate you for sharing your story and think that, we just have to be really persistent in trying to raise awareness. And I think that's why this initiative is so powerful.
I completely agree, and thank you for that. And I do want to clarify. I actually went back and spoke to my primary care physician after my diagnosis. I switched primary care, if I'm being honest, but I did go back a few months later after my surgery and just shared. I hold no ill will. I know that I'm a rare patient, but what I shared with her at the time was, I know that in medical school, I've heard that what you're told is, don't look for zebras, look for horses, right? And I said, well, sometimes it is a zebra. I'm a zebra, and that you may never see another patient like me again. You probably won't, but I think that it's also why it's really important that as patients we really document and be persistent. And I wish, looking back, that I had been more persistent and not wound up in the ER with a 13-centimeter tumor. So thank you.
There's one comment in the QA session that I want to share with you, Laura. Laura, thank you for sharing your story and driving the patient awareness. I think that's an important one that we can not emphasize enough. Neil, since you were just speaking, there's actually a lot of questions around cutaneous leiomyoma and the question, what can we best do? You saw one of these questions in the Q&A session already. We had questions beforehand. What are treatment options? What can I do? There's nobody who can help me. So I quickly just wanted to ask you whether you can comment on that.
Yeah, sure. And I guess one aspect that doesn't come across in some of the dialogue around cutaneous leiomyomas is that the burden at the level of a patient can vary so widely. And there are some patients I look after who've got isolated multiple lesions, and they might have 15 or 20, and sometimes over a number of procedures. I never see them again because they're like, look, thanks, you fixed me. And then they're just getting screening, and that's all, their review is. So then on the other hand, I've got some patients where from very early in life, they have large segments of their body which are, covered with confluent lesions, so like 300 or 400, all covering an entire leg. And I've, shared permissions with image with Christian along these lines before. And I think there is really the need to assess each patient as an individual, and then think about all the different modalities that could be applied and maybe are most appropriate to try in these individuals. Surgery can be quite definitive in some scenarios, and in some of my patients where that's worked, I've had a lot of positive outcomes. But you also sometimes stuck in this scenario where there are hundreds of tumors as to what to do in those individual patients. And really there has to be consideration for the site, the location, the limitations, where often when you cut things out and you try to stitch them back together, you put tension on the surrounding tumors and pain on those lesions too, for example. And so that is one strategy which has to be sort of tailored in a bespoke way to the patient's site and tumor number and locations and symptomology. There are other ablative approaches like lasers, and we will have heard of things like freezing of lesions. These can maybe temporarily flatten some lesions, but we know that these are often quite deep in the dermis of the skin, so they're not often ones where the likelihood of recurrence is low. In fact, it's fairly frequent to recur from these procedures. And then in terms of medical therapies, people speak a lot about calcium channel antagonists. I look after about 7 or 8 families where we've got variable responses. Some have a very good response, some have no response at all. And so really there isn't a sort of a one-size-fits-all for HLRCC in the skin. The other layers that we have explored with patients locally here is to work in partnership with anesthetists in pain clinics, because there are some combinations of therapies in some healthcare systems which are only accessible through them. there is also sometimes the scenario where there is a impact beyond just the pain and limitation of function, but when these are, you know, very much impacting on the psyche of the person or their self-confidence and their well-being. And so ideally, you want to access a multidisciplinary team, which has got access to clinical psychology support for patients who may want to choose to access that. So really, we need a holistic approach for patients living with HLRCC. And in the skin, I think it's very easy to put across that, you know, to the pathologist who correctly labels these lesions as benign on the microscope. That doesn't, you know, capture the journey of what a patient has to live with and, you know, the symptoms and what goes on over their life course. So yeah, there isn't an easy answer. For some patients, thankfully, surgery can be helpful, but often, you know, there is a dialogue. There needs to be a relationship of trust because, you know, sometimes the first approach may not work, and there needs to be a sense that, you know, we're in this together because, you know, ultimately it's a long-term relationship, right? You know, you're seeing each other each year, there's screening, you know, trying to fix the problems. So yeah, that's my strategy anyway.
Yeah. Thank you very much. This, I think, was extremely helpful, but also shows there's no simple answer, right, for everybody. And it requires really physicians that know and are willing to invest time into finding out. And also comes with the point that we might, that has helped in other rare diseases, need, you know, objective patient-reported outcome tools with which we can quantify pain and quality of life, but in a disease specific manner. There's no questionnaire that helps for all, but I think that's a very important aspect that can help at least down the road to kind of, you know, identify people that need more care. Also is related to a question we have in the Q&A section. Some of those will take them to the conclusion session later. One is really related to this, Neil, but you had a comment first. You raised your hand.
Yeah, only very briefly to say that, you know, the same frustration that's there in the clinic when we can't advance things has to drive the research, right? And we have to try to understand mechanisms of pain, understand why across, say, patients that I look after that have like 300 or 400 leiomyomas in a cluster, when they come to me for, you know, surgery, sometimes they're saying, look, I know I've got all of these, but it's these 8 which are really giving me a hard time at the moment. If you can help me with those, you know, that will make a huge difference. And so I really think that, you know, that there is so much more to be done in terms of understanding these lesions. And one of the barriers that, you know, happens in the funding space is that because the pathology label is that this is a benign lesion, often some of these things may not rank as competitively compared to the malignant aspects of the whole condition and other, you know, conditions. And so there is this need to maybe, you know, carry the impact that we see in the clinic through to you know, drive the will to support research in aspects of the condition that may not, you know, have a immediate life-threatening impact. And interestingly, across other genetic tumor syndromes, there are different patient organizations and groups that are now pushing for, look, what about these other aspects that have been relatively understudied? You know, should we do more to study that? So I think research is the answer.
And networking and asking patients what's the most relevant questions, right? This is something that can only work if we're in touch with each other. This is something, if I, from other fields that I work in a lot and where I have a lot more patient networks already, if I ask the question, what's the most relevant thing? It's never the thing the doctor would say. It's very often the question, the things that have an impact on my quality of life. And that is entirely different things. And in the end, you will be able to reconcile those, but you need to ask. Now, along these lines, there's the question in the Q&A session, what would you say the likelihood is to find doctors who know about this? Everyone I've asked about, you know, it doesn't really know. And there is sometimes more coincidences that lead to the fact that somebody made the diagnosis. And there I would quickly ask Laura again, what's your view on that? What would you say the likelihood is to find those doctors? And how would you, from a patient perspective, find those doctors? And then it'll be a very national answer, actually. I can answer this for Europe, and other people will have to answer it for other countries.
Thank you. You know, I think this is where the patient education really comes into play, honestly, because again, I had never heard of HLRCC or FH deficiency or anything like that until literally after my surgery at UCLA, when the oncologist came in and said, "Do you have bumps? You know, do you have fibroids?" So, which is a common experience, right? And I do think that that again, this is where it's really crucial that we are visible in the space, that we are visible with working with not just oncologists, but with dermatologists, with OBGYNs, with primary care physicians, and making sure that they are aware of us and that this is a possibility. Because quite frankly, again, I'm extremely fortunate. I'm in the Los Angeles area. I can go see Dr. Shuck, right? But I went for years without being diagnosed properly, and that is extremely common. So what I would say is I think you have to be, and unfortunately, I think as patients, at least in the United States, you have to be extremely aggressive in searching out who the experts are in the field, asking other patients, who do you see, who do you know that you can go to, especially if you're someone that's not presenting with renal cancer, right? If you have the syndrome, you've been diagnosed with the syndrome, but you don't have renal cancer, I think it's extremely crucial to look into which specialists you can see that will help you monitor it, that you're not winding up as a stage 4 patient like me. I know that's probably a kind of a dissatisfying answer, but unfortunately, I think it's just the reality of where we're at right now with this syndrome.
It also means we have to work on this together, right? And there will be, for example, another thing we'll do in July. I think there will be a webinar towards European nephrologists. And these things we have to do to create awareness about this. When we raised this topic to the European Rare Disease Reference Network, the answer was, are there any patients at all? We're not sure we should go down these lines, right? Even in these communities, it is, and now they're supporting us very heavily. This is the greatest thing that we're in touch and doing this together now. We're centrally there, but awareness is key. And when it gets to the non-renal manifestations, that's a very special topic. And Outi raised her hand, and I think uterine fibroid tumors are one of those.
Yes, thank you, Roman, and thank you everyone for your talks and comments so far. We're making progress. We're making a big change here. So my name is Outi Uimari. I'm from Finland. I'm a gynecologist. I did my PhD on fibroids, and I've investigated HLRCC-related fibroids. I currently work as an associate professor, and I have a research group, and we study fibroids and endometriosis. And according to the knowledge that we have so far, and all of us doctors have an obligation to update our knowledge and our skills. It's one of the core features of being a doctor. So there's lots of knowledge so far, and women with HLRCC with FH mutation have uterine fibroids with a penetration of 80 to 100%. So nearly all women have fibroids. And nowadays, women have gynecology checkups, they have ultrasounds, they have ultrasound screenings in the early pregnancies. And the patients I've been seeing here in Northern Finland, they've possibly been checked every year for the past 6 years or so. So, and the gynecologists who've done ultrasound examination for them, they've documented this patient has some 20 fibroids. They've had MRI, and the radiologists have seen these fibroids, but the pieces of the puzzle just haven't come together. So, and these fibroids, when they're being removed during hysteroscopy or myomectomy, or on hysterectomy, the pathologist sees these fibroid tissue. They have a higher density of blood vessels than sporadic fibroids. So these can be identified. And I've been studying this topic for over 10 years now, and it's quite nerve-wracking actually, because there's lots of publications. There's been presentations on yearly conferences on national and international level, and these rare but very different type of fibroids are being presented. So, but the knowledge, just how do we get that in practice? Maybe this is something we need to talk about, and finding the ways to inform our colleagues in practice. And thank you, Laura, for sharing your story, because in the end, this is the real life. This is the whole aim of clinical medicine, of academic medicine, and the research that's been raised here. So I'm very happy for the Alliance, happy to be invited to take part, and I'm very motivated to contribute any way so that we can make tomorrow a bit better than today.
Thank you very much, Outi. Your motivation and enthusiasm there actually motivates us again. So this is great. I think there's much to do, and actually now the QA session is taking off as well. We will have to move parts of the discussion and parts of the answers to the conclusions session just for time reasons, and we will answer some of the questions just in a written form. Now I'll try to take care of that while we move on to Christian's talk now. And Christian, looking very much forward to learning from you.
Can you see my slides?
We see them not in presenter mode yet.
Okay, and then you hear me okay? Perfect.
Yeah, we hear you okay. There's one question in the chat actually that I just want to raise before, because it is on the question whether 2SC test wouldn't be good, and I will skip this now. Yes. I guess you're gonna allude to that in some way.
Yeah, I will actually talk in a couple of slides about 2SC because it's very important. I'm glad I put this information. But first of all, I would like to thank you, Roman, and Jan for making this possible. And for me, as a scientist, I've been working on fumarate hydratase for more than 15 years, and it's tremendously exciting to have all these experts in HLRCC, but also more importantly, the patients. This is why we do our experiments. I'm also very excited that some of the lab members are here. So I really hope they will get some even more motivation when they see what we're doing is actually meaningful. So today, I want to give something slightly different compared to what Jan just showed, that is, more clinical perspective, but I want to give a biologist perspective. So some of the things I'm going to say are probably things that you already know, but bear with me. I decided to do this following the information that we give you when we say that HLRCC is a tumor predisposition syndrome. I want to break down what this means so that we clarify some of the terms, and then we make sure that we are all on the same page. Then we can discuss. So why do we call HLRCC a tumor predisposition syndrome? Tumor predisposition syndromes are disorders in which family members have higher chances of developing certain types of tumors. In HLRCC, as we will go a little more in details, these genetic alterations, this higher than average risk is caused by genetic alterations of a gene called fumarate hydratase, and I will explain more in detail what fumarate hydratase is. But why then I say that tumor predisposition syndrome regards certain types of tumor? Well, because as Ian just put it very clearly, HLRCC is very unique in the type of tumors that are presented. We have, as I would just say, skin lesions, uterine fibroids, and FH deficient renal cancers. But are these tumors the same? Why do we need to distinguish them? And here I want, again, more for the audience here, I want to distinguish between what is a tumor, what is a benign tumor, and what is a malignant tumor. First of all, a tumor is an abnormal mass of tissue. Here is just depicted as a mass of cell in our body. And we distinguish benign tumors from malignant tumor based on their ability to stay where they are. So technically, we can classify benign tumors as these masses that are restricted in the tissue, whereas the malignant tumors, we see very often that the cells that are in the tumor evade, they often move in other tissues, they become metastases, and this is very dangerous, of course. So going back to the definition, in HLRCC, we define leiomyomas and uterine fibroids as benign tumors. I know that there was a question that in the chat, and we discussed it very extensively, that it is true these tumors, skin lesions and uterine fibroids are benign, but this doesn't mean that they are actually easy to treat at all. This doesn't mean that they are not painful or they are problematic. Now, as we have also discussed in HLRCC, kidney tumors are highly invasive, actually amongst the most invasive tumors in the kidneys, and this is why they are classified as cancers. And again, another technical term, I just want to spell some of maybe the confusion that around the terminology that we use, that cancer arising from epithelial cells, and epithelial cells are cells that are around our organs, they are classified carcinoma. This is why sometimes we call it this renal cell carcinoma. As Jan also said, and this is also very important to keep in mind, that there is considerable variation in the symptoms from family to family, and in terms of presence of skin lesions versus uterine fibroids or kidney cancer. And at the moment, I don't think that it's very clear what are the determinants of this family to family variation. Now, going back to the definition of a tumor syndrome, I want now to delve a little bit deeper into the causes of this inherited syndrome. And here we go to the root cause of this. So HLRCC is caused by mutation of a gene called fumarate. And in order to understand what fumarate is, I just want to give a very quick overview of cell biology. So if we take any tissue or any tumor type in our body, and we go deeper with a microscope, we will see that every part of our body is composed of this little unit called cells. And inside the cells, we have another specific area called the nucleus, where all the genetic material is contained. And here, this is just a representation. As you know, genetic material is built up of DNA. And this DNA, very simply put, gives us the instruction for generating proteins. These are structures that exhibit a certain specific function. Now, going deeper into this genetic material in our nucleus, I present here our 23 chromosome. This is our way of storing genetic material, and in particular, fumarate is located in chromosome 1 in both female and male, and this is where the mutations start to arise. More into details about the genetics, this is not being touched yet, but HLRCC is also considered autosomal dominant inherited syndrome. Why? Because, and here you have two parents, and this can happen both in case of the father or of the mother, it doesn't matter at the moment. Just look at the schematic here. If one of the parents harbor this mutation in fumarate in one of these genes, and the mother doesn't, then we have a chance of having two of the sibling affected by the same mutation, and this will give rise to therefore a 50% chances of developing HLRCC also in the siblings. Now, one thing that is very important here is that this is called autosomal dominant disease, because just one mutation of one of the two allele that we have in our DNA can cause the disease. But why is that? Because it has been demonstrated that in HLRCC, even if we harbor only one copy of fumarate, and in our DNA we normally have two, during the course of a life, due to a process that is called loss of heterozygosity, the other allele is mutated. So eventually, in tumor tissues, we have both allele mutated or one allele is lost, and this will give rise to this tumor in all the tissues. At the moment, the causes of loss of heterozygosity are biochemically and technically, from a biological point of view, completely unknown. We know that, for instance, DNA damage or other things that happen during aging can affect this process, but we don't have a clear understanding. So I want to also clarify the difference between HLRCC and another disease caused by fumarate mutation. In this case, the genetic perspective is very different, because in this case, the mutation is present in both parents, and therefore we have one possibility out of 4 to have sibling or progeny with one, so with both allele mutated, which means that this person would be affected by a much severe syndrome called fumaric aciduria. In this case, the patients are affected when they are born by severe metabolic disorders, and unfortunately the outcome is not very positive, and this is very rare though. Now I want to explain a little more in details what is fumarate. I told you very briefly that fumarate is the gene that is mutated in chromosome 1, and it encodes technically for a protein. A protein, this is just how it appears in our cells. Of course, this is highly magnified version, but a protein therefore does something. And what does fumarate do? This is very important for understanding the biology of fumarate loss and HLRCC. So fumarate technically is an enzyme. And what does it mean? An enzyme is a protein that acts as a catalyst. That means that it makes some chemical reactions that occur in the body much faster. And now, if we zoom deeper into the cell, as I told you earlier, this is the unit of our tissue, and we go deeper with a microscope, we can start seeing that the cell is organizing also into different structures. One of these structures is the mitochondrion. The mitochondrion is where fumarate is by and large, and this is where fumarate exerts its metabolic activity. Fumarate is part of a very complex metabolic cellular reaction, which is called the Krebs cycle. And the fumarate, okay, this is moved, I'm very sorry, this is just, so fumarate is here. It converts fumarate to malate in the Krebs cycle. And the Krebs cycle is a biochemical pathway that converts food, nutrients, this can be sugars or fats or protein, into eventually energy. And the process through which the food is converted into energy is called metabolism. Keep this in mind. So fumarate, the enzyme that converts fumarate to malate, is now a very important metabolic enzyme. And what are the consequences of fumarate loss? To understand this, as our laboratory, we use several models, and I just want to clarify this also for all the members of the audience here, that we work with multiple sources just to get bigger chances of finding something when human samples, for instance, are limited. But we start from investigating samples from patients, from some of you. We can talk about skin lesion, there's cutaneous leiomyomas, but also renal cancer. Very often we work with cellular models. The laboratory of Marston Linehan, for instance, has been essential in providing some patient-derived cancer cell lines, but we also generated cell lines that mimic what happens in the epithelium of the kidney, thanks to the generation of engineered mouse model. So as you can see, we need to work with multiple sources to figure out what happens when cells lose fumarate. And to make a long story short, through the years, many investigators and our laboratory have tried to focus on what happens when fumarate is lost in the mitochondria. And one of the main consequences of fumarate loss is the accumulation of metabolite fumarate, which is the substrate of fumarate. I told you earlier that the enzymes are in charge of making some chemical reactions to occur. In this case, the reaction is between fumarate and malate, and therefore when fumarate is mutated, fumarate goes to very high levels in the cell. So we and others have confirmed that fumarate is truly a hallmark of fumarate deficiency. And eventually, we and others have proposed this idea that fumarate is partially, we believe, responsible for tumorigenesis, for the cancerous transformation upon fumarate loss, to the point that fumarate has been considered an oncometabolite that is a metabolite that is aberrantly accumulated, and it can actually induce this cancerous transformation. It is important to know that in this case, fumarate is accumulated only in conditions where fumarate hydratase is mutated. This doesn't happen, for instance, if you eat a lot of food, if you are in a normal condition and you eat a lot of food containing fumarate from other sources, because the cells are very good in converting fumarate in normal conditions. Now, one important aspect of fumarate biology, and I want to highlight this because it will become important for the discussion, is that fumarate, and this is its chemical structure, has the ability to bind to other structures in the cells and bind to proteins in a process that is called succination. And this gives rise to a modification of this component of proteins that are called cysteines, creating what we call technically 2-succinylcysteine. And this is why Jan just mentioned that we use 2-succinylcysteine antibody to detect fumarate hydratase loss, because indeed we and others have developed this antibody that can detect fumarate modified proteins. And I don't have to go through this because Ian already shown beautiful images, but if you take, for instance, the kidney, and now you stain the kidney tissue with fumarate hydratase and with this antibody against 2-succinylcysteine, you can see where the fumarate hydratase deficient cells are, where a fumarate is accumulated. Now, this accumulation of fumarate has many other consequences, but we can go in details later. But one of these consequences is to modify not only proteins, but also this free amino acid, which is called cysteine, and also cysteine in another important metabolite in the cell, which is called glutathione, a very important antioxidant molecule. This means that this modification can be detected in the bloodstream of HLRCC patients. And there was an effort from one of my colleagues, Lian Zheng, in Shanghai, who actually measured using a technology called metabolomics, these blood metabolites, and you could find that fumarate-modified metabolites are very concentrated in the blood of patients. So this is, of course, very important when we consider markers of fumarate hydratase deficiency. Now, I just want to bring some open questions from the biologist perspective. One thing that is very important, and very often it is asked by some of you, that when are diagnosed with a fumarate hydratase mutation, you want to know whether this mutation is actually a consequence of fumarate hydratase activity. And there is now a repository of all the fumarate hydratase mutation. This is called CleanVar. This is where you can actually see whether mutation has been characterized before. But of course, there is a very important issue, and this is from a paper recently published by Brian Shu, who is here. This is a great effort to understand whether this mutation that very often have not been characterized from a functional point of view harbor a biological outcome, that is that fumarate hydratase is no longer working. So these variants of fumarate hydratase are called variants of uncertain significance, or there is conflicting interpretation of pathogenicity. And they come up with a very clever way to measure and to mimic this mutation just in a vial and measure the activity of fumarate hydratase. And they actually figured out that out of 74 mutations that they analyzed, half of this mutation were actually pathogenic, and they would give rise to inactive fumarate hydratase. So as we were saying earlier, that there might be even more fumarate hydratase deficient patients out there, it is correct, and we still need to do more work in order to understand whether when a patient is identified with a specific mutation, this can give rise to a pathogenic effect. Now, a very important point that our laboratory is very much focused, and not only ours, but many laboratories in HLRCC, is to identify whether there are ways to prevent or treat HLRCC. And one aspect that we have been focusing on very much is to understand how this fumarate hydratase deficiency alters cellular metabolism. and why this is important. I've told you earlier that fumarate is an important enzyme in the process of metabolism. And what we found is that when you lose fumarate, the cells, in order to survive, need to readapt quite extensively metabolism. And metabolism is way more complicated than just the Krebs cycle as indicated here. So you can imagine that the entire metabolic network, the entire set of nutrients that are utilized by the fumarate deficient cells changes. And this gave us the opportunity for us to investigate ways actually to kill selectively the cells by removing specific nutrients. And this is something that we are actively working on this. So it is important then to keep on working on the research that identifies this, what we call metabolic vulnerabilities. That means that we can remove or add nutrients that will selectively kill these fumarate deficient cells. This will also be important to identify actually whether there are metabolic changes that affect the mechanisms behind loss of heterozygosity. That means that we can actually not only cure the fumarate deficient cells, but actually prevent the formation of these fumarate deficient cells when loss of heterozygosity occurs. And of course, one very important aspect is what happens to the skin lesions. And this, as I just said earlier, it is still very much unclear what happens, both from a metabolic point of view, but also all these other things about fumarate happen in these tissues. Now, the other point that I want to make to conclude is that we know that we call fumarate an oncometabolite. I mentioned the activity of fumarate towards this modification of proteins, therefore protein succination, which we have used for detecting fumarate deficient cells, but actually there's a lot of work that has been done around this oncogenic activity of fumarate. And here I'm just presenting a few names, but I don't want to go into this. What I want just to show, and the reason why I put this slide, is that by understanding how fumarate acts in the cells, we can actually start devising potential inhibitors and strategies that Marston will explain much more in detail later. And we want to identify, therefore, some of these cascades that are activated by fumarate that can be blocked, and combined with these metabolic vulnerabilities, definitely remove these fumarate deficient cells. There is one last point that I want to mention, that recently there has been an important discovery that connected fumarate loss, fumarate, and inflammation. And inflammation, of course, seems to play an important role in HLRCC, both in kidney cancer and very likely also in these cutaneous leiomyomas. So this is something that we are actively investigating. We want to understand whether, for instance, inflammation plays a role in pain, even in the skin lesions. And actually, what was mentioned earlier, and now I've basically described all these effects of fumarate loss. The work was done predominantly in kidney cells, just because we want to definitely do something for kidney cancer. But as we have heard many times, we need to understand what happens to fumarate deficient cells also in other tissues, in particular in those affected by HLRCC, that is the smooth muscle in the skin, and also the smooth muscle in the uterus. However, we need to understand also whether other cells are affected by FH loss. And this is exactly one of the projects that we are carrying out at the moment in the lab using these genetically modified mouse models. So with this, I would like to conclude. I hope I gave an overall an overview of what fumarate is, how it contributes to HLRCC, and importantly, I wanted to highlight the possible connection between fumarate loss, fumarate accumulation, and these potential oncometabolic functions of fumarate. And this oncometabolic function can be used to our advantage, both to identify potential targets, but also, for instance, in the case of protein succination, to use this as a way to detect fumarate deficient cells. And with this, I would like to conclude. I don't know if there are questions, or I'm happy to take any questions straight from the audience.
Thanks, Christian. this was a great overview and introduction into the question why there is tumor formation at all, right? And what's the cause behind all of this? Well, we may move again some more questions to the end of this. There are two specific questions to your talk. One is the question whether the lack of heterozygosity is thought to be why the symptoms become worse as we age.
Yeah, it is certainly possible. We know that now here in CICAD, where we are working on an aging. This is an aging institute, and we know that aging actually increases the chances of mutations, and this is inevitable. So for sure, this will increase the chances of loss of heterozygosity, and this is something that we are working on at the moment. But we don't have the answer. That is the point.
Marston also had a comment here.
I was just going to say one thing. We and I'll talk in a minute, but interesting. We do not see that clinically in kidney cancer. Let me just put it that way. In this disorder, we would say it's a stochastic. It's an event by chance. We'll say stochastic of losing the second copy, as Professor Frezza explained so beautifully. We've seen first tumors. We've seen a lot of tumors in teenagers. We've seen first tumors in age 10, at least here we're at the NIH. We've seen first tumor in 77-year-old. Okay, so we say lifelong, but I would just say our experience, certainly with renal tumors, which is pretty easy to quantitate, we've not seen increasing with age. I would just say our experience with that is. But anyway, so we'll see. We have so much to learn, but it's we'll see. But anyway, I just want to put that.
Thanks. This is absolutely important. I think we need more statistics. We need to understand more the mechanisms. For sure. Thanks. Yeah.
We may also need more data on the question whether there's really loss of heterozygosity in every single tumor, right? This is something, at least in other fields right now, and in PKD, we always thought this was the case. Now we look deeper and find there is actually second hits in every patient, but these second hits can be environmental as well and can be changes in crystal formation, hypoxia, signaling by ischemia, etc., PP. So there's much to learn probably, and that's also again why we need more biosamples from more patients to answer these questions. There's another specific question as to signaling downstream of fumarate levels. The other studies have shown that elevated fumarate levels can cause a range of other issues, including inhibition of HIF, which can induce oxidative stress. Does HLRCC elevate fumarate enough to induce similar issues? And then link to the question whether this could cause atrial fibrillation.
Okay.
Not simple to answer.
I
can answer. I mean, I don't mean to. We'll let Dr. Frezza go ahead. Professor
Frezza. No. Actually, I was saying that Professor Linehan should answer this question because he contributed to this discovery. So yeah, please.
Well, no, I would say discovery, but I mean, it's whatever. We all work together. But just one thing, we have not seen atrial fibrillation. It's not saying it's not there, but we have not seen it in our patients over the past 37 years. So I think it's at least uncommon anyway. And so we'll see. And we feel that just as Professor Frezza was saying, that the effect on things like HIF, really on something called dioxygenases, something that affects HIF degradation, probably, we think, is probably why some of these people might be at risk to develop pheochromocytomas. We know that other genetic models of those enzymes affected people do have a propensity to get pheochromocytomas, paragangliomas, etc. So I don't know for sure. We're looking at that right now, but that's what we kind of think. But anyway, so.
And on top of that, I guess the degree of HIF formation you have in HIF stabilization you have in individual patients may also have an impact on the growth rate of tumors and so on, beyond the pheochromocytomas. But for the pheochromocytomas, I think it's very likely that HIV plays a role, right? Based on what we know for VHL and so on. But the AFib, yes, I agree. I mean, the systemic fumarate hydratase increase is not that relevant either, right? I mean, how much is that, Christian? Do you know?
I mean, the fumarate
circulating, not fumarate hydratase, fumarate.
Fumarate. I mean, based on this study that I showed, fumarate doesn't seem to accumulate in the blood. So we see the product of fumarate succination, but not fumarate itself. But there are multiple reasons why this could be. Fumarate can be released in the urine. We have never tested patient urine, but in the models that we have, fumarate can be released, and probably this is why we don't see it in the blood.
Yeah. Great. We'll answer all others either in the written form or at the end of this symposium. And with that, it's my pleasure to ask Marston to share his view on the management of HLRCC-associated renal cell cancer.
Okay, hang on just 1 second and let me see how to share here. Here we go. Okay, is that coming across?
Yes, that works.
Okay, thank you very much. So I'm really honored to have been asked, and I'm really happy to become a member of the HLRCC Alliance. I mean, it's we're so happy to work with anyone and everyone on this disease, and I've learned so much today. I've been very touched. I've learned so much from the speakers so far. My word, we could go on for about 2 weeks talking about this disorder. But I am at the let's see if we get this to work here. There we go. Yeah, I'm Marston Linehan. I'm at the National Cancer Institute in Bethesda, Maryland. We are at the National Institutes of Health. We're part of the United States government, and so we need to say work for the public, and we're happy to see patients from really anywhere in the U.S., but really anywhere in the world if they want to travel. Or we do all sorts of consults, virtually and this, that, and the other. But we're very, very interested to see patients, and we don't charge anything for care. We're happy to see just about anybody affected with this disorder. And I won't talk about this because I'm going to talk about kidney, but just listening to about cutaneous leiomyomas and uterine, and all I can say is yes, yes, and yes. In other words, oh my word, we think about kidney. I'm a urologic surgeon, but we've been managing these patients since 89, actually, 1989. And the cutaneous lesions, I want to second what's been said. We've just got to work harder. We've got to do better on this, and I've lost one to suicide, actually, and another one I'm worried about. But it can be really a devastating thing. The cutaneous has been mentioned, and I also want to second what was said about the importance of uterine leiomyomas. Absolutely, this is the most heartbreaking thing so many times for many of these young women, and maybe to lose their uterus early and that and the other, and maybe not have babies. Gee, I just say we just got to do better with this as well. So our ultimate goal here, of course, obviously is therapy. And patients with advanced kidney cancer, of course, is, as we say over here, a 4-alarm fire for us. But on the other hand, our real goal is prevention, as I'm sure it is for all of us. But it's going to happen. I'm sure of it. But we just got to get there, and we can't do it. I have to tell you this: we can't do it here by ourselves in Bethesda, Maryland. I'll tell you that. So we're thrilled to work with other people, and any resources, cell lines we have, we're happy to ship them to anywhere in the world. We do that all the time. But happy to help. This was our first experience with this. We reported families with this. In 95, actually, we called it renal carcinoma type 2, but we reported 2 families. But it was renamed and redescribed better than we had. It now goes, of course, by HLRCC. This was our first patient in 89, a little 18-year-old that came, and I saw her and took out her left kidney, and a pathologist said, "Marston, I don't know what this is. It's something new." We managed her, but she already had advanced disease, and I lost her 7 months later with metastatic disease, and that really started our experience. This was her family. I think this might have been the first family sort of reported with this, but and since it took us 18 years to figure out what she actually had, and between the time I saw her and when we found this family again 18 years later, we lost 7 members of this family with kidney cancer. And since then, we actually lost the 8th up there, 3-7. I need the color in red, sadly. But so this can be an aggressive form of disease. This was one of the, I think this might have been the second one we saw, 21-year-old from Florida who came up of Cuban descent, big tumor in his kidney in the vena cava. And I took out his kidney and the disease in the vena cava here, that middle thing here you call. And we thought we had it out, but this was new to us, and we lost him 21 months later. So this can be a very aggressive disease. Talking about the kidney, so what you can see in the kidney, for those of you who aren't so familiar with this, is you can see 3 things. You can see a solid tumor in the kidney. You can see that here in this patient, this 52-year-old. You can see this small lesion here. That was the tumor. So you can see solid tumor. You can see cyst, a benign cyst in these patients. And you can see, and we'll talk about this one, you can see tumor inside cyst. So we spend hours going over these imaging, looking at these things, looking very carefully, because we do not want to miss a tumor. This was a 32-year-old, sorry, we saw, and a number of years ago. And I operated on him on February 22nd, 2002, actually. And he came with this cyst, but we also thought he had tumor inside cyst, which he did. A very small tumor, only 1/2 centimeter, and his father had died at age 35 of advanced kidney cancer. And when this young man presented to us, already he had disease, even that very small tumor. Already he had disease here, which you can see, and you've heard about the pathology above this. This was metastatic disease that had spread. We didn't know what to do. I mean, my word. So we could have just taken out part of his kidney, but we took out the entire kidney and everything. And he was disease-free for 16 years. And then sadly, his disease recurred, and we eventually lost him of advanced disease, I'm sorry to say. But as has been talked about, this is the pathology. It's kind of, we use the word pathognomonic. It's very clear to an experienced pathologist looking at this, and you see these cells. And the one thing that you always kind of see here is this is something inside the cell called the nucleus, and it's orange, so it's called orangophilic. And it's a this is a nucleoli that's inside the nucleus, and it's got a perinucleolar halo there, which is kind of characteristic. As I mentioned earlier, we were shocked by this. This is a 10-year-old. We've seen this in 3 10-year-olds. This is the latest one we've seen is 77. This is a 77-year-old. I'm happy to say we got this out. She is now 83 and doing fine. And if this hadn't been detected, she wouldn't be 83. I can say that. So we therefore developed an approach to management where we recommend imaging every year, starting at age 8. Our recommendations are a little different than you heard earlier, but we don't have any corner on wisdom. It's just kind of how we think and whatever. But this one I mentioned was one came. She was 24 and had this cyst, and you could see these 2 little lesions in here. if this were not HLRCC, you'd say, watch it, it's no problem. We operated on her, and these can be very invasive. So we took out, much larger than just the lesion there, but our pathologist called me and she said, gee, Marston, look at this, it's unbelievable. I said, what do you got here? And we looked at tumor inside the cyst, but she said, look at this. She said, this tumor has infiltrated all up into the kidney. And I said to her, don't tell me I left disease there. And she said, no, you didn't. You guys went really wide. You're fine. But so this is very different than the way we manage many other types of kidney cancer. And so these need to be handled with kid gloves and are really, hopefully someone who's got experience of thinking about the management of these. We'll talk about that in a minute. And this was another one who was 63. This was questionable. We couldn't really tell for sure from imaging whether there was something inside that cyst or not. We kept doing imaging. Finally, we saw something. We said, well, maybe that's a solid lesion. And if we've got a maybe in one of these patients, we recommend surgery. So we operated here. Most of our surgery here at the NIH, National Institute of Health, we do robotically, but not these. We do these open. And when we operate, we go wide to make sure we get all of the tumor out. And this woman had that tumor, and yes, it was a very high-grade invasive tumor invading into the normal kidney. We took out a number of lesions. She also had a cyst, okay, and it was benign, no cancer, but she also had cyst in which cancer was growing. You can see it here, small tumor, and we're just glad we got that out, and she's done fine. Now, this was a 52-year-old. I showed you his thing a minute ago, and he actually had multiple tumors. I had seen him first when he was 32 and had taken small tumor. A small tumor was removed. This was 20 years later. It is now, and he had tumor there. We took that out, and I showed you this a minute ago. As you can see, very small tumor. It was 9 millimeters, less than a centimeter, but we went wide on this because we know how to respect these tumors. And our pathologist said, my word, look at this. She said, it's gone through the capsule, in other words, outside the kidney, but it's also invaded into even a small tumor like that. They're lethal when they're small. And so he's done fine. So this is also kind of a little bit of a lesson for us. When we see people, we image them every year. Something comes up small, we get it out, and they do fine. This guy now is 67. I think we've taken out 9 tumors. He's doing fine. He's doing great. And this was his 17-year-old daughter. Same deal, 17-year-old. Her tumor was invading into the capsule, the outside of the kidney, and very aggressive growing into the kidney as well. This was one we saw when she was 43, and we knew she had HLRCC. She didn't want to be followed by us. She wanted to be followed on the outside. We said, okay, fine. Every year imaging, but you know how it is. She didn't get her imaging every year. She got imaging 3 years later. And the radiologist on the outside called this normal. But we wouldn't have, in retrospect, I mean, it's okay. But, she had a little lesion there. And, but, everybody doesn't understand all this. Anyway, 4 years after that, we got a call from her doctor saying, hey, I think we have one of yours. This was way back in 2010. And yeah, she had this large tumor. And we took that out, and she already had, the disease had already spread, and it eventually took her life. So we do recommend, please, imaging every year. And this is another patient with this little tumor here. And again, you can see it's complete deletion. And it was mentioned earlier that sometimes these can have oncocytic features, sort of look like what's called an oncocytoma. And this one here, you can see it is. And of course, as Professor Frezza will tell you, these are full of mitochondria, which is why they look that way to the pathologist. So we do not recommend managing these people with surveillance, with watching them, like we do a number of other types of genetically defined kidney cancers that run in families. This is a very different ballgame. Here, we recommend that surgery not be delayed. surgically, we recommend wide margins, and we do these open. We know these patients are at risk for multiple tumors in the kidney. In other words, multifocal, we call that, and bilateral, in other words, in both kidneys. And we know, or at least our experience is, that they are at risk for life. And again, as Professor Frezza mentioned, this gene was identified a number of years ago on the first chromosome, chromosome 1. And then we have characterized our families with the FH mutation, and we can now, test everyone in the family who's at risk and determine who's affected, who's not. We follow nearly 900 patients currently from about 350 families, and with the blood test, we've come up with a positive blood test, 98% of the families. So it's a very good, reliable test. And again, as Dr. Frezza mentioned, when fumarate hydratase is inactivated in these patients, they undergo a metabolic shift, as he mentioned. And one of the things is they're very dependent on sugar, because the normal way of metabolizing glucose that he talked about in the mitochondria is inactivated because of that oncometabolite feature he talked about, the succination a minute ago. And to make a long story short, that messes up the normal function of the cell so that they can't do the normal metabolism as he talked about, and they need a lot of sugar, okay? And they're dependent on that, okay? So, all right, but for us, for people managing patients and everything, that's important because it tells us that a certain test called a PET scan can be very precise when trying to find these tumors in patients. This is a patient over here. You see this MRI. Patient who had surgery before, you can't tell. Do they have recurrent tumor or not? You can't tell. It's kind of hard to know. But when you do a PET scan, it lights up like a Christmas tree, as we say over here. And so this shows a number of patients who have HLRCC kidney tumors, and this is the PET scan in the middle here. So these are very positive. So this gives us another tool to help diagnose and hopefully manage these. This is a patient, sadly, who had disease that spread the liver. You can see how positive that is on PET. Another patient, sadly, very, very positive. And this is one that had disease in the lungs. We weren't sure, a little hard to know on the chest imaging, but when you do the PET scan, oh yeah, right. This is disease here, and this is disease there. Yeah, right, copy that, I got that. And this patient here, the man, the 32-year-old that we talked about a minute ago, the PET scan on him, as you can see, this PET scan is also very, very hot on the skin. And that does not mean it's a cancer. It's just, it's on, yes, as I mentioned, these are not tumors. These are not malignant, these cutaneous Leiomyomas. And sometimes the pathologists who are less experienced with these might say these look like cutaneous leiomyosarcoma. And I can't speak completely to Europe, but on this continent, we've never seen a cutaneous leiomyoma that was malignant, and we have never seen a uterine leiomyoma that was malignant. Our sense was our fellow pathologists who looked at those were maybe a little less experienced in looking at these. This is the uterine leiomyomas that ladies can get, as you know, and you can see this PET scan lights that up. And again, as Professor Frezza mentioned, when the fumarate hydratase is out, what he talked about was the fumarate goes up, okay? And this can affect, as they were talking a minute ago, an enzyme that affects something called HIF. And the only reason I bring this up is because we have a little bit of a sense about this. We were desperate to develop some sort of therapy for these patients. We tried everything known under the sun between 1989 and 2010. And then working with my colleague here, Dr. Ram Srinivasan, we developed an approach to therapy of a drug called bevacizumab, which is an antibody that targets VEGF, and another drug called erlotinib, which affects glucose transport and different things. And so this was the second patient we treated sadly, with metastatic disease with this disorder. We had biopsy proof of this, and we knew about this disease. And she came back a few months after we started therapy, and she had a complete response and has been a complete response for 19 years. Just in closing, I'll show you this last patient. This is one that we saw came up from the south. He'd had a kidney on the left side. It was removed. This is a PET scan I showed you a minute ago. And sadly, he had this amount of disease. Dr. Srinivasan treated him with this bevacizumab and erlotinib. And we've seen some very remarkable things. Not a complete go away here of disease, but very, very dramatic decrease in his disease. This is what I mentioned a minute ago. This is the PET scan, another way to look at it. And this was before treatment here. And this is on drug here. And again, as Dr. Frezza mentioned, based on some work we did here, but on his unbelievably elegant publications he mentioned a pathway called cGAS-GO, which lights up, as he mentioned, the immune system in the cell. So could you use that to target these? We have now started adding that with Dr. Srinivasan. Dr. Srinivasan has a new protocol here, adding a drug like that targets that pathway to this therapy that we do here, bevacizumab and erlotinib. We're doing that trial now, and we're very hopeful about that. We have some sort of anecdotal evidence on patients who've had some very dramatic response with targeting that pathway that Professor Frezza helped characterize so elegantly with the cGAS-GO and PD-L1, PD-1 pathway. That's a immunotherapy thing. And so I would say there are some very exciting things. I would also just say that, again, I'm at the National Cancer Institute, and our new director, is Dr. Kim Rathmal, who's a medical oncologist who studies kidney cancer, including HLRCC, rare kidney cancers. We also, there's a whole lot of exciting work going on outside of our group, outside of the US, and obviously, and in Europe and in all over the place. We're very thrilled about it. We're happy to work with other people, happy to help. But I just want you to know that in this country, anyway, there is high level support for this. Dr. Rathmal is the director of the whole National Cancer Program. Also, when President Obama visited my laboratory, we talked to him about this disease and showed him some things in the microscope. And then a little while later, he asked me to come down to the White House, and you can still see this on video. You can pick it up online, people tell me. But I gave a presentation here. This was in his Precision Medicine Summit, and he was rolling that out. And I spoke about HLRCC and the time. So all I guess I'm trying to say is in the US, there is very high level support for this. You're not alone. And we've got a long way to go, but we're by your side. And I would, I think I'll stop with that, and very appreciative of the kind invitation to meet with you all. And I hope this will be the basis for a more collaborative projects between our group and other groups. As I said, we are happy to work with other people. We don't know everything here at Bethesda, and so we've got a lot to learn, and we're happy to work with other people. Thank you very much.
Thank you, Dr. Linehan. This has been a great overview of all the work over decades, actually starting early on and showing the progress as well. Both on the diagnostic and the therapeutic level, there has been considerable progress that exploits partly the metabolic defects in HLRCC associated RCC. There is a couple of questions. We answered a lot of questions already down the road. There's a couple more that I would like to address to you, but Jan just raised his hand and may want to start.
Yes, thanks, Professor Linehan, for the talk. I think you introduced a lot of very interesting aspects. One aspect has been already the content of a question regarding the use of PET scans in the setting of HLRCC. The question got asked also regarding uterine fibroids and the utility of a PET scan in that setting.
What?
And there was a question asked regarding uterine fibroids and the utility of PET scans in that setting. But I want to ask on another detail. Usually we do MRIs for screening, and these obviously have a better spatial resolution as the PET scans can offer, right? In what setting would you be happy to use a PET scan, for example, to differentiate a benign cyst from a cyst-containing tumor? What size of tumor would you need to?
You mean cyst-containing tumor in the kidney? Okay, let me get back to the pelvic. Sorry, I didn't mean to be misleading about that. All I meant to show there was that you see the mechanism of PET positivity in the skin and in the uterus, but I wasn't. So we're like you. We would never use a PET scan to characterize the lesions in the uterus. We would use an MR just like you. So we do a pelvic MRI, and that's how we characterize those. And of course, we work very closely with our gynecologic surgeons here, and start screening in sort of late teenage years, our young women with MRIs, and have them see our gynecologic surgeons, so they can talk to them about things of this, that, and the other. And anyway, and so in the kidney, that's a very good question. The problem with using a PET scan for kidney for those equivocal lesions is that the PET tracer is excreted through the kidney. Therefore, the entire kidney lights up. Now, what can be done, so that's not useful, unfortunately. But what we've done a couple times is, but right now we have trouble scheduling this, is to do a PET scan and do it delayed. Let it delay and delay and delay, come back in 3 hours, and then redo the PET scan, and it will have washed out. And in one or two that we've done, the tumor will still light up. So it can be useful, but we're working on other ways that should be better to help us further characterize those lesions in the kidney than doing a PET scan.
Thank you.
Thanks. There's actually a couple of questions along these lines in the question and answer session. Partly answered already. There's one on the question. There's problems, to get insurances cover surveillance, PET scans, and whether there's advice how to deal with this. I mean, general monitoring is still MRI, but in cases where PET CT is needed, again, that will be a very national question. I think this one comes from the US, so you might allude to that. In Europe, that will be different for every single country.
Yeah, in the US, it can be difficult. I mean, we hear that from patients all the time, the ones that are getting annual screening. So what we do sometimes is write letters to their insurance company. I mean, but as you know, the medical system in the US there's complexities to each individual insurance company.
Yeah. And that in the end depends also always on collaboration between the patient and the treating physician to solve this problem. And it can, in my experience, be solved if there's a lot of initiative and motivation on all sides to solve it. But it is a difficult one and depends on very individual settings. The other one comes from the fact that you showed, there's often cysts that may contain very tiny tumors, right? That you want to pick up early and that you would remove when you're doing surgery anyways already. The question here now is that based on this, if someone with HLRCC showing benign cysts on their MRI should do something proactive towards biopsy or surgery. Biopsy will be difficult in surgery as well in this setting, but your opinion would be great.
No problem. Our sense is the following. We don't like to biopsy HLRCC tumors. We know, because we learned this a long time ago, I'm sorry to tell you this, but that when we do surgery, if we spill cells, they're very different than other types of kidney cancer. You spill cells of these, they'll cause tumors in the retroperitoneum, the back part of the abdomen. And so we do not recommend biopsy of these things. In our sense, if it's equivocal in our hands, that's surgery. I mean, it depends on how equivocal it is, but I mean, if we might re-image them in 6 months or something, but if we think it might be a tumor. Now, we work very closely. We have a team of people here who work on this. We go for everything as a team. We also work very closely with our radiology people. And one in particular, Dr. Ashkan Molayeri here, is extremely experienced with these. I'm sure you've probably seen his publications, but we've published a fair bit on the imaging of this. So he's very experienced. So we're fortunate with that. So anyway, but if someone, in our experience so far, if someone has benign renal cysts, we're not worried about that. Okay, we watch them, but we don't have any evidence that patients with renal cysts are more likely to get renal tumors than other patients with HLRCC who do not have renal cysts. Have we seen tumors develop in those cysts? Oh, yes, we have. However, we've seen a whole lot of patients with renal cysts who are in their 70s and nothing ever changed. So, that's our sense in June of 2024.
Yeah, and I think, I mean, most of us, we definitely in our center would totally share that. If you think about cysts, it down the road also goes towards cysts is even more of a problem in pretty much any renal cancer. Then you're going to puncture the cysts and you have everything that's in the cyst fluid floating around, which makes biopsy a hard thing anyways. There's a comment by Brian Shook to the hosts and panelists that I just want to share. A PET scan is largely useful for distant disease, and MRI or CT is the gold standard. And I guess that's another important one. And that Bosniak score may not play a role in patients with HLRCC. Not everybody may be aware of Bosniak score. That's how we normally classify cysts, and to get an idea whether we're looking at a complicated cyst or a simple cyst and whether there is any further action needed. But this classification was not developed for people with HLRCC. So any cyst that looks complex in an HLRCC patient will need some kind of management in an individualized fashion and cannot rely on the Bosniak classification. I think that's a very important point when we think about education of colleagues in the field as well. In the interaction with the radiologists on board. There are no more questions in Q&A session, and we're time-wise at the end of this as well. This has been a great experience. Thanks to all of you for your contributions. Thanks to all of the participants in different time zones, all coming around for something that people believe is an ultra-rare thing. I think we already show by the fact that we have so many people here today that this is something that is meaningful, that needs answers and needs people involved. We'd be happy to network as much as we can with all, stakeholders in the field, patients, physicians, researchers. So I just quickly, to have that up for you again, share my screen once more with the link to the survey, which is one way to get involved, and the email address through which whoever you are, you can reach out and get in touch, and any contribution will help down the road to get this towards its goal and keep it growing. And I think today has been a very, very important step. We should continue along those lines.
Thank you so much, Roman.
Jan, the last word should be to you anyways. You were the key person who set all of this up and get this running with your continuous work and talking to everybody and getting everybody on board. And I think this has been a very, very good experience. So thank you very much.
Thank you. Yeah, I'm also very happy how all this came along. I think it's really nearly exactly 1 year ago that we first met in a really small format. And since then, I think every reach out we did, every person we contacted who was involved or is involved in any way or form in HLRCC care or is a relevant stakeholder has been so so positive and willing to contribute to the very important cause. And in the end, I'm very happy that we could have this symposium today. If you fill out the survey and leave some contact details, we will definitely keep you updated on the activities of our alliance.
That's another thing. If you want to be included in future emails and so on, write an email. We're happy to include anybody in mailing lists. We just don't want to bother anybody either. So we get too many mails, all of us, but just write us an email. We're happy to include you in future meetings. And if you have ideas of societies that may be willing to partner, right, and to support and endorse future activities, also very welcome. We're glad that we already have partners, but we need more, and this is interdisciplinary. So we're currently working on the different fields involved to get everybody on board. So thank you very much again. And I hope to see all of you in the near future for future meetings.
Thank you.
Thank you.
All.
Thank you. Bye-bye.
Bye. Thank you.
Thank you.
Bye. Bye-bye.